Welcome to Unit 4, Lesson 1, where we will be reviewing treatment for depression in children and adolescents. And the verse guiding this lesson is Psalm 23, verse 4. Even though I walk through the darkest valley, I will fear no evil, for you are with me, your rod and your staff, they comfort me. I think this verse speaks to the positive protective factor that faith and religion can be for patients who are suffering with depression. So we need not forget about spiritual care and the importance of spiritual interventions. Depression in children and adolescents does not necessarily resemble depression in adults. It doesn't really look the same way, though there are the same constellation of symptoms, including trouble concentrating. With kids, that looks like academic decline or poor academic function, academic failure. As well, decreased interest in usual activities or anhedonia, where they just aren't participating in things. So they're dropping out of clubs and not going out and getting together necessarily with friends as much as they used to, but they may still, because that is a peer expectation. So the isolation will not necessarily appear quite as severe with adults. They both can have that disruption of sleep or appetite, either increased or decreased. The epidemiology, it's estimated that about 1 to 2% of prepubertal children can be diagnosed with depression at any given time, and 5% of adolescents. The cumulative prevalence is 12% for girls and 7% for boys. So we do see that there's a higher incidence overall in girls. And depression is usually recurring, but with children, it can be spontaneously remitting. So that's certainly something to keep in mind, though treatment is certainly indicated, and psychotherapeutic approaches, though, may be all that is needed, not necessarily combining with medication. So depending on the severity, and as you know, we have the specifiers of mild, moderate, or severe in the DSM-5. So the average episode for a depression is about 7 to 9 months. So it can take a while to improve. And there's about a 40% probability of recurrence in 2 years and a 60% likelihood in adulthood. Now, these numbers can increase if the patient is treated only to a partial response and not to full remission. And again, medication is not the only way to achieve remission, but robust focus on psychotherapeutics and behavioral approaches is important too. And here's a slide that really just outlines or highlights some of the differences in the presentation of depression in prepubertal children as well as adolescents and adults. So we see with young children, irritability, temper tantrums, and noncompliance is very common, and the affect is very reactive. And there's frequently a lot of associated anxiety or comorbid anxiety disorders, as well as comorbid ADHD. Another hallmark for the young child is somatic complaints. Now, we do see somatic complaints with adolescents as well. With adolescents, you're more likely to notice the change in appetite as increased appetite with weight gain. And hypersomnia is very common in adolescence. So here we have teens sleeping the day away. And as well, we do have the same irritability, but in the adolescent, it's noticed as grumpiness or hostility and difficulty with frustration tolerance. We do see with adolescents as well some extreme sensitivity to rejection, which could be falsely perceiving themselves as being put down or criticized. And that has a result of causing problems in maintaining relationships. So, depression in youth is a result of complex interactions between biological vulnerabilities as well as environmental influences. So, we have nature and nurture going on again. The biological vulnerabilities could be from the child's genetic predisposition as well as those prenatal factors or exposures. And environmental influences could be the children's family relationships as well as the experience of stressful life events. Parental depression is um, a very consistent risk factor for depression in offspring. And some of the common comorbidities associated with a depressive disorder in children and adolescents include anxiety disorders, post traumatic stress disorder, conduct disorder, as well as an adjustment disorder with disturbance of conduct, attention deficit hyperactivity disorder, obsessive compulsive disorder, as well as learning difficulties. Anxiety disorders are the most common comorbidity, and about 28% of children or adolescents with a depressive disorder also have an anxiety disorder. And it's estimated that the incidence of a comorbid diagnosis of ADHD along with a depressive disorder is around 7%. And just like with adults, when considering a diagnosis of depression, there are some important differentials to consider. Now, one of the most important is considering unipolar depression versus bipolar depression, because the treatment of a bipolar depression with antidepressants can really cause a worsening of patient outcomes. Another consideration is the experience of a severe depression with psychotic features, and that needs to be differentiated from other psychotic disorders such as schizophrenia. Now, as well, substance use disorders can present with a depressed affect or a comorbid depression. The depression may be comorbid or it may be a symptom of the substance use disorder, of the CNS depression. And again, really differentiating between depression and an adjustment disorder with depressed mood. And so the way to do that is going to be looking at the time frame, how long have the symptoms been going on, and whether there was a precipitating factor or a significant adverse childhood event that occurred prior to the onset of the symptoms. And then, of course, just to look at the experience of a dysphoric nature because of life situations and circumstances. Children with disruptive behavioral disorders can become very demoralized when their relationships are strained in the home, when they're ostracized by their peers in the classroom, and perhaps also experiencing some academic failure. So it's really important just to consider all of these factors when making the diagnosis. Is depression the primary diagnosis? Is it a comorbid disorder? Or is it just an emotional state? We certainly know that the mood can just appear depressed, but that's not the same as meeting criteria for a diagnosis of a depressive disorder. And as always, we want to use our behavioral rating scales both for screening. So we have the PHQ-9, which is a good screening tool. And whenever a screening tool is positive, we want to go and do a more in depth evaluation which you can do with either a self-report tool, but even a higher level would be the clinician administered rating scales as well. There are a number of evidence-based psychotherapeutic modalities that the nurse practitioner will use either on their own or in addition to treatment with medication. And it's always good practice, especially with young children, to initiate some of these first and assess the response. So some of those therapies include cognitive behavioral therapy, activation therapy, interpersonal psychotherapy, dialectical behavior therapy, and mindfulness. And cognitive behavioral therapy, or CBT, helps to identify links between mood, thoughts, and activities. It helps to challenge automatic thoughts that may be distorted, such as negativism or negative thoughts, and to increase the focus on more positive thought patterns and activities. And it helps to build skills to maintain relationships. So, we will be going in depth into the process of cognitive behavioral therapy because it is one of the most common modalities to help treating both depression and anxiety disorders. Behavioral activation therapy can also be very helpful in working with youth. And the focus here is on the self-monitoring of activities and mood and focusing on planning positive activities to engage in. And so that may be the homework, setting goals of what types of activities the child will participate in the following week. So we're scheduling activities and structuring them in a positive way. It also includes a focus on problem solving and social skills. And it's important to really be realistic. And so you can have a hierarchy construction where you help the child to rank how easy these activities would be to accomplish. And given their different situations, some may be more difficult than others. They may not have access to some resources. Now, shaping is a behavioral approach which is used to train healthy behaviors. So, the way that shaping is used is that you start by reinforcing at a low level, but then the expectation increases. And so, you need to have a higher and higher goal in order to receive the reinforcement. And so behavioral contracts can be very helpful in supporting behavioral activation therapy. So here you want to have the adolescent sign a contract actually that is reinforcing identified healthy behaviors. The best approach for psychotherapy for children and adolescents dealing with depression is interpersonal psychotherapy. This is focused on the present, which is very different than the psychoanalytic approach. So, the goal is to focus on interpersonal conflicts and as well identify any areas where they have lost social support or are lacking in need of additional support. And an additional focus is the improvement of interpersonal skills. And the therapist does this by discussing relationships and setting goals for ideas for improving relationships and some problem solving and focus on coping skills, as well as some psychoeducation about depression itself and what it is, and help to improve self esteem in that way. Dialectical behavioral therapy is another approach that can help children and adolescents, especially with depression. And DBT is similar to CBT, but instead of focusing on the cognitions or the thoughts, it's a focus on the dialect or um, ways of speaking. And the goal is to improve interpersonal effectiveness and practice assertiveness and interpersonal problem solving skills. Now, while doing this, it's important to teach the individual some coping skills that include ways of tolerating distress, such as self soothing, distraction, and creating lists of pros and cons for dealing with situations, and a large focus on emotion regulation, helping to accurately identify and label emotions, and then look at ways to change them to a more positive area and identify obstacles or things that prevent that from happening. Mindfulness is another important tool for enhancing distress tolerance. Mindfulness is defined as paying attention in a particular way on purpose in the present moment and non judgmentally. John Kabat Zinn is one of the lead theorists in this area. The goal for mindfulness is to stay in the moment, in the present, not worrying about what's going to happen in the future, and not ruminating over things that have happened in the past. Attending or paying attention is another important focus. Mindfulness focuses on the use of the senses, hearing, taste, touch, sight, and these are some of the foundations of mindfulness: a non judging attitude, being patient, having a beginner's mind, just being curious about things, trust, non striving, not judging what is, but just looking to understand and accept, and as well letting go of any negative or harmful or distracting thoughts. So here's our case study. We have Susie, who is an 11-year-old female, and she presents via telehealth video conference with her parents. Her parents are concerned about her academic failure. She was previously an AB student, and now she's been getting B's and C's. She's been isolating and very irritable. Her intake has decreased and she has lost some weight. She quit the volleyball team and said she doesn't want to play anymore. So, what is your plan for assessment? What are the behavioral rating scales that you might use? What are some of the differential diagnoses you might consider here in addition to a depressive disorder? Certainly, with academic failure, we could consider attention deficit hyperactivity disorder, inattentive type. And what are the considerations for treatment? Hopefully, one of the first things that came to your mind was a psychotherapeutic approach, such as CBT, mindfulness, or interpersonal psychotherapy. Because we know that while medication may be indicated at times, certainly psychotherapeutic interventions are very important. Medication is certainly also an important treatment modality, and there are several antidepressants that are FDA approved for use with children and adolescents. Of course, we have the black box warning and always need to inform the child and parents to be on alert for any signs of suicidal thinking. Now, Sometimes a child presents with some suicidal thinking as the chief complaint. So here's where we want to navigate carefully, and it's really the expectation that the suicidal thinking should decrease with treatment and not increase. So it shouldn't get worse and it should not change. And so, certainly, education and ongoing monitoring for suicidal thinking is important. And one thing to be aware of is that there is often a placebo effect with treatment of medication. And that's when we see an immediate response. And so sometimes that can be a placebo effect. Another thing to consider is the problem with undertreatment, treating to a partial response rather than remission of symptoms. And again, be aware of which medications are FDA approved and when using an off label medication to be sure that there's evidence supporting it and that you've informed the parents that it is in fact off label. So, some of the approaches for treating depression in children and adolescents are SSRIs and SNRIs. So, those are the most common. You might consider using L-methylfolate if the child has a polymorphism on the MTHFR allele. And as well, we do have the FDA approval of esketamine or Spravato for treatment-resistant depression or acute suicidality. And acute suicidality is approved for use with adolescents as well as adults.